Welcome everybody. Today we are talking about status epilepticus. Status epilepticus is a state of prolonged uncontrolled seizure. It's a very common emergency department presentation that is potentially life-threatening. You have to do rapid diagnosis and emergency treatment because if you do not terminate the seizure very rapidly, it leads to long-term neurological damage and sometimes even death. Various treatment strategies are available, but benzodiazepines remain the mainstay treatment. What is the definition? Definition is very important for status epilepticus. It is a single seizure that lasts more than 5 minutes, or multiple shorter duration seizures but without regaining consciousness, without neurological recovery in between the seizure. I mean, there is a seizure of 1 minute, then the patient do not regain consciousness. After that, another seizure 2 minutes, another seizure 2 minutes, but in between these seizures, shorter duration seizure, the patient do not regain level of consciousness. This is again regarded as status. What is refractory status epilepticus? Refractory status means that the patient remains in convulsion despite 2 IV anticonvulsant, which is usually diazepam. What are the causes of status epilepticus? The causes, the patient either have history of epilepsy or no history of epilepsy. In patients with known epilepsy, the most common causes are drug non-compliance, drug withdrawal, or drug therapy alteration. I mean the dose alteration or making it once daily instead of twice daily. Other causes of status epilepticus in patients with history of epilepsy are a patient is taking their drug regularly but have an intercurrent illness, a pneumonia, an infection, an influenza, metabolic abnormalities like DKA, co-ingestion of drugs that lower the seizure threshold. If the patient have no history of epilepsy, what could be the causes? It might be drug withdrawal syndromes, example, alcohol. Patients who are alcoholic, if they withdraw from alcohol, for a few days they will get tremor, tachycardia, sweating, and also decrease intellectual function. Then one day after 2 to 3 days they will get convulsion. Barbiturates, benzodiazepine withdrawal. Also in acute structural brain disorder, example stroke, subarachnoid hemorrhage, trauma, cerebral hypoxia. Commonly stroke can cause convulsion, either new stroke or previous stroke. It's expected that every patient with stroke, they have chance of 10% to get convulsion later in their life, especially hemorrhagic one. CNS infections, example meningitis, encephalitis, abscess, and sometimes even tumors. Clinical presentations of status epilepticus. The clinic, it refers to a prolonged seizure of any type. So what type? Because seizures have type. It might be, presentation might be a clinically obvious tonic-clonic seizure, which is common, or it might be just subtle focal seizure, or sometimes even just a bizarre sensory alterations associated with partial seizure. So it might not be only a tonic-clonic convulsion. It might be just a partial seizure which is not stopping, is also regarded as status. What are the investigations? All patients which admit to the hospital for status epilepticus should have a blood glucose level, especially in the first few minutes of admission. Urea electrolyte, especially sodium and chloride, are important. Also send for magnesium and calcium because these are might be also the cause. Full blood count. Also other tests according to the patient's level. For example, you might suspect a brain mass, a stroke, a hemorrhage, you send for CT scan. You suspect a sepsis, you send for blood culture. You suspect that the drug level is not is not adequate, so you send for serum anticonvulsant level, which is most of the time not available. Lumbar puncture for CSF evaluation, especially for meningitis. Toxicology screen, if you suspected any drug overdose. IBG, to look for acid-base balance and also to look for other components in IBG. An EEG is rarely required. However, it might be needed in cases of non-convulsive status. So what we mean by non-convulsive status? It means that the patient is having seizure in their brain. There is abnormal activity in the brain, but they are not convulsing. The patient is not moving. There is no any convulsion movement, just a seizure in the brain. So how do you detect it? You just detect it by a change in the EEG waves. The management of status epilepticus, as we said, it's a medical emergency. It requires urgent, aggressive therapy in order to limit long-term damage, especially neurological damage. The outcomes may increase if you increase the duration of status epilepticus. There is progressive loss of responsiveness to diazepam. Therefore, early initiation of anticonvulsant is the key for the successful treatment. So what you do? You wait for 5 minutes. You don't give anticonvulsant. During these 5 minutes, you have to treat ABC. If the patient is hypoxic, hypotensive, hypoglycemic, so you have to treat this. You have to put the patient on left lateral position, call it recovery position. Give them oxygen. And also, if the patient is suspected to be alcohol abuse or poor malnourished, you have to give them IV Pabrinecus, vitamin B1, or call it thiamine. So if from the time of the convulsion started until 5 minutes, the convulsion not stopped, so this is called status epilepticus. At that time, you have to give them benzodiazepine, usually lorazepam. But lorazepam is not available most of the time, so you have to give them diazepam 10 milligram, diazepam 10 milligram IV. If IV access not available, then you have to give them rectally, or you can also give them midazolam if available buccally. So from the first time, you have to give them diazepam 5 minutes. You wait for 10 minutes. If still not the convulsion not stopped, you give them another diazepam. Then you wait for 10 minutes. If convulsion not stopped, it means refractory anaphylaxis. You have to go to the second line. What are the options in the second line? Nowadays, they say the best second line is to start with Keppra. What is Keppra? Keppra is levetiracetam. We will come to that. If Keppra not available, you may give phenytoin. If the patient is already on phenytoin, you have to give them phenobarbital. So you choose one of them, but try to choose Keppra as the first second line option. At the same time, you have to call RCU. Why? Because during this time, until 35-40 minutes, if convulsion not stop, the RCU doctor, the anesthesia doctor, may decide to do rapid sequence induction. It means endotracheal intubation. They may give them one of the drugs like propofol, midazolam, thiopental, sometimes even ketamine. So this is the how to manage a patient with status epilepticus. I have to take your attention that sometimes RCU is not available, or sometimes the anesthesia doctor cannot get consent from the family, so they are not intubating. What you do? You have given Keppra, not successful. You start a second line treatment. You start phenytoin, or you given phenytoin, you may give phenobarbital. This is new guideline. Anyhow, diazepam, and in 25th minute you have to start the second line. So benzodiazepines at our first line, they enhance the effect of neurotransmitter GABA. GABA decreases neuronal activity, so you enhance their effect in order to decrease the activity. Benzodiazepines may cause respiratory depression, so you have to monitor them. You have to monitor SpO2 continuously. They may cause hypotension, so do blood pressure measurement periodically. The options are diazepam, lorazepam, and also midazolam. Which one is better? Diazepam is available in the IV form and also rectal preparations. Rectal diazepam is as effective as IV one. It terminates about 70%. So this is the effect. IV diazepam also terminates about 60 to 80%. However, lorazepam may be more effective in terminating seizures. Phenytoin is long-acting drug. The advantage is that it prevents seizure recurrence, but it has delayed onset within 10 to 30 minutes. So you have to start with diazepam before giving phenytoin. The side effects are local infusion reaction, arrhythmia, hypotension. That's why nowadays it's not preferred as a good second-line treatment. Do not co-infuse them with glucose. So do not put phenytoin inside glucose water because it might lead to formation of the precipitates. The rate should be slow, not more than 50 mg per minute. Coming to Keppra. Keppra is frequently used nowadays as a second line. The dose is 50 mg per kilogram. Usually the ampule is 500 milligram. So for a patient who is 50 kg, for example, you multiply by 50, by this 50, it becomes 2,500. So during convulsion, you have to give 5 ampoules IV. Under many people, they give less than this dose and the convulsion not stopped and they say this is not effective. No, you have to give adequate dose of levetiracetam, Keppra. Coming to barbiturate, again, they like diazepam, the similar mode, they will modify the effect of GABA. They are not standard first-line treatment for refractory status epilepticus. The agents include phenobarbital, thiopental, pentobarbital, although thiopental usually used as an anesthesia drug. So, what is status epilepticus is any seizure more than 5 minutes or multiple shorter seizures without full neurological recovery in between. 2/3 of patients with status epilepticus have no prior history of epilepsy, so you have to search for the cause. Causes in these patients might be due to drug withdrawal syndromes, especially alcohol, acute structural brain injury, CNS infections. In patients with epilepsy, status epilepticus most commonly results from reduced intake of normal anti-epileptic medication, or non-compliance is the most common cause. IV benzodiazepine terminate the seizure in about 80% of patients. They should be used as a first line. Lorazepam is more effective in terminating seizure than diazepam, although it's not available in our hospitals. 10 minutes should be left between the doses of anti-epileptic drug to allow time for the drug to work and avoid compounding any adverse effects. So you start from 5 minutes, then 15 minutes, then 25 minutes, then anesthesia at 35, 40 minutes. So you give diazepam, and second line and anesthesia. And thank you.